Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today I'm joined by Dr. Fernanda Almeida to discuss her latest paper, which is entitled Continuous Positive Airway Pressure and Mandibular Advancement Splints, the Choice Multicentre Open-Label Randomized Clinical Trial. Dr. Almeida is a professor of dentistry at the University of British Columbia, Vancouver, Canada. She leads the dental sleep medicine program and is also on the editorial board of the Journal of Clinical Sleep Medicine. Hello, Fernanda. Many thanks for joining us today.
Thank you for inviting me and selecting our study for this podcast.
Could you provide a brief summary of your study and its main findings?
Our study, or as we call the choice study, we made the aim to compare objective compliance of CPAP and mandibular advancement splints. Often mandibular advancement splints do not have in the past the ability to provide that objective adherence on a nightly use. But also we wanted to understand if the patients had both therapies available, what would be their treatment usage patterns? Would they use mostly one or the other one, and how would they go with that? And finally, really assessing what would be the efficacy in the reduction of sleepiness and other patient-centered outcomes with all those strategies, meaning either just the CPAP or just the appliance or having both therapies there. We conducted this multi-center. It's a double randomized trial, mainly because we had to initially titrate both therapies, so CPAP and the appliance, and then we re-randomized and we did the traditional 1 month crossover trial. And at this point, we disclosed to patients all treatment outcomes, and then we allow the patients to take home both treatments and let them use whatever they wanted. And at the 6 months, we looked at the outcomes. In terms of the results, at the 1 month crossover trial, as expected, the CPAP reduced more the apneas and hypopneas than the appliance for an average difference of 10 events per hour. And the mandibular advancement splint showed actually a higher adherence to CPAP of on average 0.7 hours a night. And when used, it was for 1.1 hours per night, which was significant. The other thing that was quite interesting is that in both treatments, we found the same improvement in terms of sleepiness, quality of life, fatigue, and even reduction in blood pressure. Now, the outcomes for the 6 months assessment after that disclosure of treatments is actually there were only 8% of the patients that were completely non-compliant. There were 8% of patients who were partially compliant to either PAP or mandibular advancement splint. 20% were using the CPAP only, 9% with mandibular advancement splint only. And the other 55% of patients were actually alternating between the therapies. And out of those 55, 17 were actually alternating within the same night. So quite interesting that this alternating therapies was what resulted in a smaller percentage of patients with persistent symptoms and functional impairments. And really struck us as well, it was the reduction in blood pressure. Although we were not powered to look at blood pressure and we only had office blood pressure measurements, we found an amazing improvement of almost 7 millimeters of mercury in the systolic blood pressure in the overall population. And when we looked at only patients with stage 1 and 2 hypertension, the reduction on systolic blood pressure was 9.6 millimeters of mercury, and for diastolic, 8.1 millimeters of mercury. So that was something that really surprised us.
Very good. Thank you. The overall adherence rate to CPAP and to the mandibular device, as you've stated in this study, was quite high, even at 6 months relative to what is published or what has been published in the literature. Could you speculate on why the adherence rate was so much higher in your study compared to others that have been reported in this field?
Sure. It's important to state that even in the 1 month crossover, the adherence was pretty high as well. And we believe that that could have accounted because patients were informed that they would have a choice of treatment afterwards, right? So traditionally, what we see in the literature, yes, it is a discontinuation rate of about 35 to 50% on CPAP, right? And we only had a very small discontinuation. So we do postulate that this is because first patient knew more about the disease. They all had to fill this discrete choice experiments. They knew they had a choice. And they would go on a nightly basis, having their own willings respected. They could choose on a nightly basis on what to use. They had options on a nightly basis.
Okay, that's something novel, I think, in this field to give therapeutic choices for the patient and letting the patient decide whether to go on CPAP or mandibular device or both. Do you think that's perhaps a secret sauce for adherence in your study?
We believe so. And I think it could be valid for other therapies as well. And actually, if we look at other chronic disease management strategies, it's often the true as well. I mean, a lot of respirologists have done that with asthma, or endocrinologists have done that with diabetes, where you allow patients to fluctuate between having different therapies at different timelines and even different times in life, right? It comes to weekends or holidays. There are different strategies that you should use between those. So I don't think it is anything new in medicine, but it was new in terms of sleep apnea management.
I think you mentioned this before that the efficacy of CPAP in terms of reducing respiratory events, apnea hypopnea events, was significantly greater than that of the mandibular device. Is there any concern about using the mandibular device, especially in individuals with high apnea hypopnea indices?
It's a very important question. I don't think there would be, but we don't truly know. Until now, we don't know exactly who are the patients who are going to be suffering for our cardiac problem, for example, from sleep apnea. We don't fully understand, is it an AHI of 5? Often we say it's more likely to be a 20. And with which type of symptoms? If it is an asymptomatic patient, these patients may not be at risk. So we are at a time that I don't think we have the question because we don't even know what would be the threshold for that patient to be at risk of having a problem under therapy.
So, respiratory events or number of respiratory events may not be the end all in terms of assessing effectiveness of these interventions. And clinicians should look at other metrics such as sleepiness, cardiovascular endpoints, and that sort of thing. Would you agree with that?
I fully agree with that. And we have this understanding often that, oh, but the field is changing so much that we're going beyond the AHI and we're looking at, desaturation burden and on and on. But what is really normal and what does truly imply to cardiovascular comorbidities, we don't know. But for sure, we need to add patient-centered outcomes such as sleepiness, such as fatigue, such as quality of life, for sure.
So let's talk about the clinical implications for the practicing physician. So, would you recommend that he or she start with CPAP and then go to mandibular device or vice versa, or both at the same time for patients who've been diagnosed with significant sleep apnea?
Well, I think all of us would know that starting already with both is economically not feasible. But definitely, we need to go away from putting CPAP on every single person that comes in without even telling them that there are other treatment options. So we need to pass that kind of way of treating patients that we have for sleep apnea and move into more patient-centered medicine, where we actually tell patients more about their options, tell the pros and cons, or educate better the patients in more therapies. And with the patient, decide what would be the best for that patient. Of course, yes, there could be some problems then with cost, right? If you start on mandibular advancement or other therapies and it is not effective. But at that point, I believe that patient would go then back to the CPAP and that patient will be really compliant, more so than if the patient started, didn't like the CPAP, didn't know about anything else, and never went back. So it is important to definitely educate the patient. And if the patients, together with the clinician, decide, yes, let's try this as my first option or my first trial, I think that's where we have to start.
Very good. Any last words regarding your study or in the field of sleep apnea or sleep apnea management in general that you would like our audience to remember?
I think we definitely need to understand for sleep apnea, and from our study, we need to understand the patient's needs, the patient's expectations of the treatments, and what does alleviate their symptoms and what suits their lifestyle. Okay, so I think that's something very specific to our study, and it has shown that often having both two therapies to alternate between may be very important. Beyond, in terms of sleep apnea in general, is really going to understand what are the metrics we need to use. What are the metrics not just for diagnosing, but also what are the metrics of an effective treatment that truly helps the patient. And as you said before, that would be safe for the patient to be on that treatment.
Well, on that, I think, very positive and patient-centered note, I want to thank Dr. Almeida for joining us today, and thank you for joining the podcast. Dr. Almeida's paper, Continuous Positive Airway Pressure and Mandibular Advancement Splints, the CHOICE multicentre open-label randomized clinical trial, is now available on the ERJ website.